Hello and welcome to the Pharmacy Informatics Professor 2020 with your host, Dr. Armin Simonian. As we've covered before, there's a very important link between pharmacy informatics and medication safety. And today, in this continuation of the Journal Club series, I wanted to revisit the ISMP website and talk about an article that was published there, and also a book that came from ISMP written by the president and founder of ISMP, and then talk specifically about medication error prevention strategies. So let's get started and go into the presentation and specifically cover this topic of medication error prevention. So I'll quickly mention that we've defined pharmacy informatics before, and we know that the pharmacists must use their knowledge to implement technologies that lead to safer and more effective medication use. So underlining that word, safer. Now, going back to 1999, there was an article that was published on the ISMP website, and it's a medication error prevention toolbox. And they start talking about strategies for preventing medication errors in general. And then years later, there was a book published by Michael Cohen. Michael Cohen is one of the heroes of pharmacy, not just pharmacy informatics, but pharmacy practice in general. And this is the second edition, so there's been 2 editions of this book. This is a must-read for all pharmacy informaticists and all medication safety pharmacists, medication errors. And the content that was included in that original ISMP website journal, or that article, that content is also included in this book and updated, and there's a little bit more depth around it. So I would recommend going and reading this book and also reading the original article from 1999 on the ISMP website. Now, I was surprised when I saw these strategies, and it was mentioned that the weakest strategies are really education and information and rules and policies. Now, when I started hospital pharmacy practice and started getting into pharmacy informatics and working on medication safety, we thought that it would be a good approach every time that we found a problem or anticipated a problem, that we would inform all of our medical staff, nursing staff, other clinicians, try to educate them on the issues, provide posters and leaflets and different methods of communicating through newsletters and other forms that problems could occur with medication use and to avoid those. And then around those medication issues and around our technologies, we wrote rules, policies, and procedures. And we thought that this would really help with establishing guidelines on how to use the different technologies, how to dispense medications, all of the activities that we have in the hospital around medication use. These rules, policies, and procedures are to be followed by all clinicians. And we thought that that would also be a good strategy. But as it turns out, according to the ISMP folks and by Michael Cohen in his book, these are the weaker strategies. Okay. And then going up the list, we can have independent double check systems and other redundancies. So every time an insulin dose is drawn up by a nurse for a patient, we can have a policy that a second nurse has to verify that the appropriate dose was drawn up for that patient and document that. Again, these are the weaker forms. Then we get into drug protocols and standard order forms, and we've kind of talked about this in terms of passive clinical decision support. So we can have order sets built into our systems, into our EHRs, and these standard order sets, best practice, evidence-based, really help us with prescribing. Moving up the list, automation and computerization of medication use processes and tasks. This is all about pharmacy informatics, the fact that we've gotten off of paper, gone away from written prescriptions, and now have CPOE and e-prescribing. And we have the eyes of the prescriber on the computer so we can provide clinical decision support, both active and passive, and then automate the medication use process with automated dispensing cabinets, smart infusion pumps with guidelines around those, and then drug libraries built in and limits on IV infusions. And then we also have technology such as barcode medication administration at the bedside to make sure that the 5 rights are followed and that the right med goes to the right patient at the right time and the right dose by the right route using scanning technology. So automation and computerization really is a great strategy, and moving forward with that is the job of the pharmacy informaticist, and doing it in a safe way. We have to involve the medication safety pharmacist. So this is where the bulk of our work is, trying to make sure that these systems are completely and properly implemented as much as possible at a given institution. Now, at the top of the list, you have forcing functions and constraints. So one example they give is having concentrated potassium chloride injection available as floor stock. This should be eliminated. It shouldn't even be there. I would say an automated dispensing cabinet, you shouldn't have those vials. Also, something like a fentanyl patch that should never be used for acute pain and should only be used in patients with chronic pain that are not opioid naive. You probably don't even want to load that patch into your automated dispensing cabinet, especially in the emergency department or general medicine floors. That would be a constraint. A forcing function can be active CDS, where if the system detects an allergy to a medication that's documented on the patient's profile, then the system can force the clinician to either stop and not prescribe that medication, or if there's a good reason to proceed, indicate what that reason is before going on. So we're forcing the clinician to stop and think and act appropriately. So forcing functions are at the top of the list, and these are the things that we want to judiciously put into place in our systems to make sure that our systems are as safe as possible. You want to keep away from the idea of doing this for everything, because it will really make our systems unusable. If it takes forever to place a medication order, even a routine one, and answer every CDS warning that pops up, that could be going a little too far. But definitely we want to use forcing functions where appropriate to make sure that serious medication errors do not occur. And this is, according to ISMP, the most effective prevention strategy. So that's a summary of these, the article and the book content on medication error prevention strategies. And I hope this was helpful for you in thinking about implementing systems and how to implement systems. If this was helpful for you, please like the video and subscribe to my channel, and I'll thank you for that. And in the meantime, stay safe, stay healthy, look after the health of others, and I'll continue to work on more episodes and hope to see you next time. Take care.